We're going to move right into the keynote. That's okay, a little milling about, but so everybody can get situated. It's an honor and a privilege to introduce friend and colleague Jesse Ehrenfeld to the group. Dr. Ehrenfeld was recently elected president-elect of the AMA, with term to start next June, and has served the AMA Board of Trustees since 2014. He's Senior Associate Dean and tenured Professor of Anesthesiology at the Medical College of Wisconsin, as well as Director of the $500 million Advancing a Healthier Wisconsin Endowment. He's an Adjunct Professor of Anesthesiology and Health Policy at Vanderbilt University, an Adjunct Professor of Surgery at the Uniformed Services University of the Health Sciences in Bethesda. He's a consultant to the World Health Organization Digital Health Technical Advisory Group, and has previously served as co-chair of the Navy Surgeon General's Task Force on Personalized and Digital Medicine, and as a special advisor to the 20th U.S. Surgeon General, in addition to nearly 15 years of service to the U.S. Navy. He's a true quintuple threat as a clinician, educator, researcher, leader, and advocate, and today he will be speaking on the future of AI in anesthesiology. Please join me in welcoming Dr. Ehrenfeld.
Thank you so much for that. Appreciate it. Fantastic. Well, thanks for having me. It is just a pleasure to be with all of you. And I always love coming to Phoenix. My in-laws live here, and I don't have to stay in their house. So it's like a double bonus. So I'm going to give you kind of a whirlwind tour from my perspective about technology development, where we're going, and I'll punctuate at the end with kind of what the current state of AI is in the field and where I think it's going, and hopefully we can have some robust conversation when I'm done. So to do that, I'll share a little bit about me, my background, my interest in technology development, and then I'll describe what do I think the key opportunities for us are as anesthesiologists in the specialty. So as Patrick kindly mentioned, this is like my 150-page CV on one slide. I spend most of my time in Milwaukee at the Medical College of Wisconsin, but I still have faculty appointments at Vanderbilt and the Uniformed Services University in Bethesda, Maryland. I've been on the AMA board for a long time. I'm now their president-elect, and spend a lot of time in the kind of technology standards development space, serving as an advisor to the World Health Organization, working with AMI and other groups. So that's kind of, that's me in a nutshell. Has anybody been to Milwaukee? Excellent. And let me tell you something. I bought 2 plane tickets for the way back, so anybody who wants to come, wants a job, wants a residency slot, let me know. Afterwards, we'll have a sign-up sheet, and you can accompany me there. MCW has a fabulous anesthesiology department that continues to grow like so many other places, and we have 24 osteopathic physicians. Round of applause for that. But we're always looking for more. So that's sort of the day job. I was recruited to Milwaukee to run something that Patrick mentioned, which is the Advancing a Healthier Wisconsin Endowment. This is a very special entity, and the history is that when Blue Cross Blue Shield of Wisconsin became a for-profit entity 20 years ago, the state ordered the assets, the proceeds of the sale of the company, be gifted to the medical school. And so that incredibly generous gift has been transformative for MCW, and I was recruited to lead this initiative. It's now about $500 million, and it's allowed us to make tremendous investments in education, research, training programs, including paying for the start of our anesthesia assistant program, which we're actually going to double the size of next year. That team is run by me, but these are the folks that actually do the hard work day to day. And I get the pleasure of running around the country talking about our work, technology, and other things. And I always like to acknowledge the people that day in and day out show up to actually make sure that these things happen. So that's me. Let's turn to technology. So I want to share with you some pictures of my son. This is Ethan, and he was born 10 weeks early. He weighed 2 pounds, 7 ounces, 1.1 kilograms, and spent 50 days in the NICU in Chicago. He needed a whole bunch of medical device technology to keep him alive. Are there peds people here? Yes, love you all. Technologies, innovations kept him alive, for which I am eternally grateful as a parent. Some technologies are more than 100 years old, right? So the warm air incubators were introduced in Paris in 1880. Other technologies, much more recent, right? So pulse oximetry from the 70s, smart connected infusion pumps, which really came along with dose air reduction systems in the 2000s. And I love sharing pictures of Ethan. And that literally, the one on the left, that was literally as they were rushing him out of the delivery room, stopped for 1 second for my husband and I to see him, and then right into the NICU. And I could share lots of photos. And these pictures remind me not just of the technologies and the devices that kept him alive and worked, but also the dangers associated with devices and technologies that have failed. Some of you may be familiar with Joel Nobel and the ECRI Institute. Joel was a surgeon and an inventor who founded ECRI back in the 50s or 60s after a 4-year-old boy literally died in his arms when a defibrillator failed to work. And he used that institute, which still exists today, it's just outside of Philadelphia, to focus his energies on how could he improve cardiopulmonary resuscitation technology, design, and implementation. And he kind of ushered into the world this era of comparative evaluation of medical device brands. It was kind of the Consumer Reports approach applied to medical device technologies back in the 70s. And there's some really, really famous work that was seminal around a series of deaths and injuries to neonates and incubators, really linked to things around thermostat failure that caused the incubators to overheat and the infants to die, and also some things around electric shock hazards. Now, fortunately, Ethan's incubator worked just fine. He did not overheat. He was toasty and warm, and it's really because of the standards that have transformed the medical device industry over the last 50 years. This is a picture from just a week or so ago. You know, in some ways, Ethan is a modern medical miracle, right? Born at 29 weeks. In other ways, it's the result of the seamless integration of routinely available medical device technology. And a lot of the work around how do we make these technologies effective and safe is around standards. How do we get better, more effective medical device standards and regulations that can protect patients from harm, like my son Ethan, when they are at their most vulnerable moments in life? So I share all this. I think about development, implementation of technologies, particularly those that are AI-enabled, where it can be much, much more difficult to understand when an algorithm is working as expected or if it's not. So, did anybody fly on a plane to get here? Did anybody fly on a 737 MAX? Excellent. Pay attention to this. So, the tragic loss of 2 Boeing 737 MAX airliners give us some really important lessons on how AI systems should and should not be implemented in medicine. Automated systems designed to improve safety can actually create danger and create harm when they malfunction. And the effects of an AI system are determined by the implementation of the system, not the designer's intent. And so the 737 has something called the Maneuvering Characteristics Augmentation System, or MCAS. And it appears that both of the crashes that were very widely reported were because of the safety system, an AI safety system that was designed to mitigate a known mechanical issue and risk with the 737 MAX redesign. So the modern high-efficiency turbofan engines in these planes, the new ones, they're much bigger in diameter than the original designed ones in the 60s. So if you mount them in their original configuration, the problem is that they would drag on the ground. So the redesign for the 737 MAX made these new larger engines fit by positioning them further forward and higher up on the wing. Unfortunately, when they move the engines into that position, it can cause the nose of the plane to drop, to pitch up during some maneuvers. And as some of you may know or remember from physics, if you pitch the nose of an airplane up too high, the angle of attack gets too great, and you can lose lift, the plane stalls, and then falls out of the air. So it turns out that to mitigate this propensity for the plane to just stall, this AI safety system, the MCAS, was designed to monitor the angle of attack sensor And if it detected a high angle of attack, it literally forces the nose of the plane down, reducing it and pitching you back to normal flight. The problem is, if you have a sensor malfunction, which is what we think happened with these two crashes, this AI system forces the plane down and into the ground. How does this relate to anesthesiology in medical devices? When you add an AI system into our workflow, the people in the workflow have to know that there's AI. We have to receive training on the expected function and any anticipated dysfunctions of the system. And people working with AI and AI tools, we can only supervise and correct problems if we know that the AI is there and we understand the outputs that it's producing. The flight crews of those two doomed airlines crashed. They had no idea that their AI systems were there. It was absent from the operating manuals. There was no specific training required. We simply cannot repeat that same mistake in healthcare. So I think a lot about processes, and my core research interests have been primarily focused about how do we use technology to advance quality, safety, reliability by making our processes more reliable and robust. And that has involved the creation of a lot of decision support tools, developing AI systems, as well as doing large-scale pragmatic trials. And I'll give you a quick run-through of what some of this work has actually looked like, and if you're interested, you can look some of the stuff up afterwards, or I can point you to the references. Prior to taking my current role in Milwaukee, this was kind of a flavor of the research portfolio, so a wide variety of both NIH and DoD funding, mostly in sort of the technology development space, with a variety of things actually also in there tied to health equity. So when you think about processes, processes are really just, a system, an action that we follow to lead to a result. And you can think about any process in healthcare, whether it's, bringing somebody through the perioperative experience or something very specific, like getting the right perioperative antibiotics, and you can understand when you have a process failure as long as you have criteria established. So, not giving the right antibiotics at the right time prior to incision, those sorts of things. And, you can categorize problems with processes, you can graph them, you can do all sorts of things. The hardest part of all these reliability analyses is often just getting the data. And fortunately, our information systems today, as we've gone through the electronic conversion process, have made this a lot easier. So you might ask, okay, given our good intentions, the incredible talent that I see sitting here in front of me, and I can say that because I don't know all of you. Now, I know Patrick, and I know that you all are very skilled. People don't show up wanting to do a bad job, right? That's not in our blood. We put on scrubs, we go to our clinics, we go to the operating rooms, wanting our patients to have the best possible outcomes. Nobody shows up wanting to perform poorly. And the generally accepted answer as to why our processes are carried out at such low levels of reliability is that it's the system, not the people. And while that may be true, it's not particularly helpful when you're trying to actually detail how we can work to improve our clinical processes. So to be successful, I would actually argue that our focus has to shift in our thinking. We've got to take a broader perspective on how we deliver care. Too often we concentrate on changing very small technical aspects of the delivery process. But often, I will tell you, those innovations make very little difference, relative difference in our outcomes. Changing how the OR environment functions, how our systems are set up, is likely to provide much greater opportunity for improvement than improving some of these technical aspects. So I think that rather than focus on small incremental gains, our focus has to shift to how do we use technologies to create unfailing, reliable systems. And as we do this, we have to embrace these tools, recognizing that all of these tools can help us deliver evidence-based medicine more effectively and appropriately. So I've done a lot of work around systems design. I thought I'd share a few examples. This is some work we did around creating a perioperative system to more effectively monitor and guide glucose management in the OR. I am not going to get into a conversation about a specific number to target for perioperative glucose control. We can have that debate maybe after cocktails, but I will show you some data that's really, I think, telling. So this is the percentage, and this is Vanderbilt data. We've published it. You've got on the x-axis the duration of the case, so really short cases on the left-hand side, really long cases on the right-hand side. And this is how often diabetic patients have their glucose monitored while they're asleep. And you might argue, okay, you've got a diabetic patient, it's a short case, 1-2 hours, maybe I don't need to check a finger stick sugar. It's kind of hard to argue when you get to hour 5, 6, 7 that it's okay to not measure glucose. Okay, keep this picture in mind. This is the next picture, this is related, same deal. These are patients we actively gave insulin to, not just diabetics, but we actually administered insulin. Again, here it's really hard to argue that 3 hours after you've given IV insulin, that it's okay to not check a follow-up sugar. Yet this is standard routine performance, and I've got these data from a dozen different centers, not to pick on any one. And so it's because we haven't put the attention to how do we create unfailing systems that can use technology to improve it. So we actually built some relatively simple decision support, a little pop-up, a reminder at an appropriate interval to say, hey, you've given insulin, you haven't checked a sugar, maybe you should do it. And it turned out we were able to drive very nicely glucose monitoring over time. This is just a statistical process control chart that shows compliance with monitoring glucose at least every hour if you've given insulin, every 2 hours if you're a diabetic patient. And we had a really, really fantastic impact on patient-centered outcomes. So we saw hyperglycemia fall in the PACU. We did not have additional hypoglycemic episodes, and the surgical site infection rate fell. That is important to those patients because when we did our analysis, just during the study period, we prevented at least 60 surgical site infections, patients who didn't have to stay in the hospital, who didn't have to get antibiotics because we better effectively managed their control. And again, we didn't tell anybody what glucose to target. We simply help people remember that if you have a diabetic patient or you gave insulin, you ought to check a sugar. And I was really pleased when this actually got incorporated into some national practice changes through one of the large EMR vendors. Okay, second example is around fluids. And this is what I describe, it's a pragmatic trial, but this was really a tech-enabled ICU fluid selection trial. So, we give lots of fluid, and the administration of isotonic crystalloid is the single most common intervention received by any patient in any ICU across the US. Something like 200 million liters of saline are given in the US every year alone. And as you all know, you've got two basic types of IV crystalloids, saline and balanced crystalloids. And there are some theoretical differences, right, when you give these different fluids that might lead to some advantages. We know that saline causes hyperkalemic metabolic acidosis. Particularly, this has been well described in animal models. It causes renal vasoconstriction. That's been demonstrated in healthy and unhealthy volunteers and can lead to kidney injury. So the question is, why are we not using balanced crystalloids all the time? Why do we use saline? Well, it turns out that nobody's done the study, a very hard, very expensive study to do if you wanted to randomize thousands of patients to find these small differences across ICU units. We were able to do this using technology. So we created basically a pragmatic trial using our information management tools to cluster randomize all of our adult ICUs and then alternate by month whether they got saline or balanced crystalloid using an electronic order advisor. So it simply recommended the fluid based on the study month. People could override it. Almost nobody did. About 98% of the time, the expected fluid was what was prescribed at the point of care. All of this was driven by our informatics tools, the order advisor, the data collection, the outcomes adjudication. Imagine trying to do this trial where thousands of patients across multiple ICUs were randomized using a traditional research nurse in data collection methodologies. It would be unbelievably expensive, millions and millions of dollars, and it would take a decade. We were able to do this basically for free over a relatively short period of time. The punchline is that it turns out there is a signal that saline causes problems, additional morbidity, and these are the two New England Journal of Medicine trials if anybody wants to look them up. Okay, so let me get back to AI. AI is everywhere. I don't think anybody would argue that we haven't entered into an AI era unless there's somebody in the room that doesn't own a smartphone. These tools track our data, the music we listen to, they tell me what I might like. Target, Walmart, Amazon, my grocery store, they all know what I shop for. They recommend things to buy, recipes I might try. We all expect AI to make our lives more automated, more efficient. But when it comes to healthcare, we're often not quite comfortable taking recommendations from something that we can't see, speak to, or know how those recommendations were validated. At the same time, we all suffer from the deluge of data that's harder and harder and harder to sift through. So I would propose that we've got to embrace technology and this concept of augmented intelligence to help us as clinicians by boosting our capabilities, not necessarily replacing them. And that's why I really prefer the term augmented intelligence as opposed to artificial intelligence, because I think it's the combination of our capabilities plus the machines that's really where we get the strength. So AI systems have tremendous strengths in processing certain things. So natural language, pattern identification, locating knowledge quickly, eliminating bias, and of course, the machines never take a day off. Humans have different strengths, right? We have common sense. We can handle moral dilemmas. We have compassion. We can use our imagination. We can abstract concepts, things that machines typically are not very good at all. So we know that if you bring the machine plus us together, you often get this sort of collected benefit. And so this study is now getting a little dated. It was from 2015, but I really like it. It's a simple one. So the best machine checker at the time, on its own, if you fed in patient's symptoms, got the diagnosis right, meaning it was in the top 3 of your differential, only 20% of the time. If you stuck your average physician in front of this scenario, they got it right about 2/3 of the time. The magic is when you bring them together, and then suddenly you can boost the capability of both the unassisted clinician and the machine together to get it right 93% of the time. So when I was in Afghanistan, I spent about 10 years in the Navy Reserve. I had this very strange experience. So, I'm standing there, I'm staffing our trauma hospital, patients are being brought in, and very obvious pieces of information. Did this patient have CPR or not, or lost? And it's usually pretty obvious, right, if someone had CPR and had their chest thumped on or not. But in darkness, with multiple patients while you're being shot at, it's not hard to imagine why there's a lot of confusion, and it's easy for very obvious things to be lost in the shuffle. So the DoD got very interested in working with our team to figure out, could we create algorithms, use AI tools to automatically sense procedures, activities, things that were happening to patients out in the field. And so the question was, what could we detect using kind of off-the-shelf technologies, putting an accelerometer on somebody's arm and having a video camera mounted in the back of an ambulance. And they funded some work at Vanderbilt to do this. This is a simulation. This is obviously not a real patient, but we did this work in concert with the fire department in Tennessee. And it turns out that when you mask ventilate somebody, when you start an IV, when you do CPR, that there are signals, right, based on the movement, the hand positioning, change in the patient's position that are pretty actually straightforward to detect. So all the things that my colleagues here who are faculty investigators are doing, you'll see replayed in a second with streams of data. And these are streams of data that are coming from a simple accelerometer worn on her wrists, as well as the video camera that's able to very, very effectively detect, okay, CPR has started, CPR has stopped, an IV was just placed, the patient was receiving mask ventilation through an ambu bag. And so you can imagine if we can detect these kinds of things in real time, you can push that information forward to downstream caregivers. Again, the DoD use case, send this from what's happening in the field back to your receiving facility, your trauma hospital, whatever. And you can imagine, obviously, uses in day-to-day practice. So the first output from that DoD-funded work was published in JAMIA, and you can find it here. Okay, so that's the intro. That's me, my perspective on technology development, involvement, and so on and so forth. Let me now shift to kind of the second half of what I prepared, which is to talk about what's ahead. What is the digital future for us? What are the opportunities? And what does this look like specifically for anesthesiologists? And I promise I will walk through what that looks like today in the field. I do want to just make mention of the AMA. So as Patrick mentioned, I've been on the AMA board for 9 years in leadership. And the AMA has taken on this concept of how do we support the physician community more effectively by supporting technology implementation adoption. And that has taken a variety of manifestations. One is we've done a lot of work to try to understand what are the key drivers of physician adoption of technologies. And it turns out that there are 4 questions. For any of my Jewish friends in the audience, it's not those 4 questions. It's a different set of 4 questions. It's, does it work? Will I get paid and reimbursed for the technology if I use it? Will I get sued, and who's liable if the technology goes awry? And then will it work in my specific workflow? And if a technology is able to satisfy all of those 4 requirements, then in general, physicians are more likely to adopt it. So the AMA has done these really nice longitudinal digital surveys looking at key drivers and adoptions, 2016, 2019, and we just released the 2022 results. Sorry, I didn't update the slides, but it's more of the same theme, and I'll give you the summary of the trends, which is on this next slide. So first, there's been an increase in the number of physicians that see an advantage in using these tools, right? So we understand that they can provide help to us. We're more willing to use them, and there are obvious things and use cases that a decade ago it wasn't clear, why we would bother. Second, tools has grown among all physicians. So the gender differences, specialty differences, age of the physicians, those things have started to melt away. So across all segments, specialties, whatnot, we're seeing adoption of these tools. Third, and this is not surprising, this is actually pre-COVID data, but it's held up throughout. Most of the adoption is in the sort of televisit remote monitoring space, and we expect that to continue. And fourth, awareness of emerging technologies like AI is very, very high. And I've got a slide that shows this, and people expect that these tools will be adopted. So just 2 summary slides, and this is fascinating. So even though you've got a lot of people familiar with these technologies, it depends on the exact segment, whether it's 40% or 80% or whatnot, very, very few people are actually using these technologies to date. It's mostly single digits. That being said, the intention to adopt these tools is very high. So people know about them, they hear them, they're familiar with the ideas, they want them, and this is sort of where we are. So let me pause and talk about equity. So, I've talked about technology, innovation, but let me sort of ask a hypothetical question, which is, what creates health? And we know that lack of access to quality health care is only one aspect of healthy living, one that we're often directly involved in through the care we provide. But social determinants often impact a patient's health or well-being. Socioeconomic status, education, mobility, access to economic opportunities, transportation, all of those things, genetic factors as well, although that's not a social determinant. There's this growing awareness that we have to consider all of these factors as an overall strategy to improve the health outcomes of our patients on a broad scale. The question is, how do these factors influence our work in technology adoption? And I would argue that they have to come together, and I'll give you a very clear example, hopefully, of what that looks like on the next slide. So has anybody been involved in a cochlear implant surgery? And these are amazing, right? So these basically, they bypass defective hair cells in the ear, extract sound from the environment, the acoustic sound gets transformed to electrical energy, stimulates the nerve, and then suddenly somebody who is either completely or profoundly deaf after implantation can have normal hearing. These are amazing tools. The thing is, when you implant this internal device, it stays there, sewn into the skin, but there's actually an external portion as well, and that external portion is kind of like a hearing aid almost. And just because you've implanted this FDA-approved medical device doesn't mean that the individual or the child is going to wear the external part. And there was one study that looked at this, and they found that half of patients with a cochlear implant didn't wear their external device full-time, meaning that it doesn't work if you don't have the thing attached. Why might that be? Well, we know that food insecurity, housing instability correlate with poor medication adherence. It's not hard to imagine why poverty, stigma of having this thing on your head might make one patient less likely to wear it than another, or to be able to buy the batteries to keep it running, which of course are not covered by Medicaid or insurance. So as I think about the development of AI tools, technology, medical devices, I would argue that we have to consider everything we do from a health equity lens, being mindful of all of the barriers that can prevent adoption. So, the disruption of our healthcare system has already begun. We are seeing unbelievable growth in the retail direct-to-consumer segment. Patients want virtual care to continue. It's a huge satisfier. There have been record year-over-year growth in investment, private equity, in digital health. And we have all of this emerging technology in AI, genomics, precision medicine, health at home that is starting to fuel things. Meanwhile, we're starting to see new care delivery models at work. And we're seeing real challenges with our healthcare systems. Does anybody know a healthcare system that's made money in the last quarter? I don't. Massive losses, right, because of the inflationary pressures, bumping up against fixed prices, right? You can't just go to Blue Cross and negotiate an increase in your payment contract because your nurses are getting 3% or 7% more because that's what they negotiate in the labor market. So we're starting to see tremendous margin disappearance, hospital closures, and all these things come together to really make us think, how do we solve what has become not just really a national healthcare challenge, but a global healthcare challenge? And there are all these trends, right? There are specialty shortages. We cannot mint enough anesthesiologists to go around. We've got people living longer, needing more procedures, more complexity that we can manage. And all of these things are real challenging for us. The only way out of this, I think, is to do two things. One is to reimagine how we deliver care, and the second is to embrace technology to make it an asset, not a burden. And I spend a lot of my time thinking about, what are the tools that our future workforce need to understand to be successful as the healthcare system changes. But it's a bit fuzzy out there, right? What is our role? How do we bring all these things together using care team models and technology to think about, what our specific function is 10, 15, 20 years from now? I don't know. But we have to be able to use these technologies to improve what we do, to return our time to the things that we're most effective at doing in ways that are thoughtful. So the question is, can AI be a solution? You all probably have seen this, Gartner hype curve, and any new technology goes through it, right? The technology is birthed, people get really excited about it. Turns out it maybe doesn't quite meet all the expectations. You fall into this trough of disillusionment, and eventually it gets integrated in this sort of productivity plateau. We're somewhere probably near that trough of disillusionment, and we've had to go through issues around standards, understanding issues that are really important around privacy, bias, validation, that we're starting to work through as we think about these technologies. And there have been only a handful of FDA-approved AI autonomous devices. The very first one was a tool out of the University of Iowa. Any Iowa people here? For diabetic retinopathy screening. It's a fabulous tool, but there are many, many more in the pipeline. So some of you may know Dr. Abraham Verghese, who wrote Cutting for Stone. He's out at Stanford. I just love this quote, so I stuck it on a slide, which is that the way here is not to think technology versus human, but to ask how they come together where the sum can be greater than the parts for an equitable, inclusive, humane care practice of medicine. And so that's really why I try to use this term augmented intelligence, where it's assistive and helpful to allow us to reach our best possible potentials. So in the last few minutes, what I'd like to do is shift to something that's more anesthesia specific. Now that I've given you the overview of how I think about technology, equity, development of these things, and I'll start by asking a question. Feel free to shout it out. Anybody know, without looking at your phone, the year that AI was first described in the anesthesiology literature? 95 in the front row. 45. 87. So it was 1952. And then nothing until 1983. And then I looked, there were 297 articles in 2021, and it's just continuing to explode. So I get all these questions. I hear these terms, machine learning, natural language processing. What do these all things mean? And I'll just say, you don't have to be an expert, but recognize there are sort of these 5 very common subfields of AI that you've probably heard of. Machine learning, neural networks, deep learning, computer vision, natural language processing, which are all tools that fall under this global concept of AI. And they're used in different ways depending on the use cases, and you'll definitely hear more. The question is, how does this in practice impact our practice? And I was so delighted in the resident poster presentation to see the Oculus VR epidural project, because ultrasound guidance and teaching are clear use cases that I'll describe in a sec. So these are the places where today there is tremendously active work in bringing AI tools into the field. Depth of monitoring, control of anesthesia systems, event prediction and risk prediction, ultrasound guidance, a bunch of work in pain management, pain prediction, and then stuff that is often not sexy, in the background, hidden away, OR logistics, supply chain, scheduling, personnel management, incredibly important. And I will tell you, it's that last bullet where the stuff is actually real and in use today. All these other things are mostly experimental and in the development stage. So anesthetic monitoring, I'll just blow through this quickly. A lot of work trying to understand how we can use tools, neural networks, machine learning, other AI approaches to predict the very age-old question of, is the patient asleep or awake, without you getting a prediction from a processed EEG monitor that is 5 minutes too late. Anesthesia delivery systems, there's a lot of work. Most of this work has actually been done in Europe around closed-loop delivery control systems. You all probably know the tale of the one FDA propofol closed-loop delivery system that was pulled off of the market. Why was it pulled off the market? It was pulled off the market not because it didn't work, it's because nobody wanted to use it. So there was a trust, confidence, workflow issue with that tool. But there are lots of folks working on how can we create control systems for ventilation management in the OR and the ICU, as well as drug delivery systems, using different kinds of approaches to get better, more effective, more reliable outcomes. Event prediction. There are many groups that are trying to understand very specific questions. Can we predict complications that are patient-specific? Do we know how long a bolus dose of propofol will last in a particular patient based on characteristics? When patients will wake up at the end of surgery? Those kinds of things that fall into kind of the event prediction space. Ultrasound guidance. You can imagine, and you can actually buy off-the-shelf tools that now have, from commercial vendors, AI capabilities enabled to help identify structures, guide proceduralists as they are performing the procedures. This is a field that is exploding rapidly, and I expect will probably change how we do things in the future, just as how, I still remember learning to place central lines without ultrasound. Do people do that anymore? Not so much. Maybe. Pain management, so there's stuff on the prediction of opioid dosing, identifying who's going to benefit most when we have limited resources from pain consults. And there's this really interesting work around doing whole brain scans and machine learning to understand how patients are likely to respond to or not to various therapies. I mentioned the OR logistics, again, schedule optimization, supply chain, personnel, people. Not sexy stuff, but this is the stuff that's real today that you will find hidden away in your hospitals and facilities actually working. So, my summary. I really believe that AI, machine learning algorithms will transform how we work. Don't think of it as the human versus the machine. Think of it as the sum is greater than the parts. I do believe firmly that these technologies will give us the potential to scale our capacity. Think about telepresence, virtual monitoring, remote care delivery. Those are things that we desperately need as we hit a wall around the healthcare workforce globally, whether that's the physician, nursing, or other healthcare worker community. And I would say that AI won't replace anesthesiologists, but anesthesiologists who use AI will replace those who don't. I really do believe that. So this is a picture I took a little while back, me in the OR doing a neuro case, and I counted, because I like to do this sometimes. I had 53 parameters going, 7 continuous waveforms, plus my EHR data, lab data coming back, reminders, decision support. What you can't see hidden in the corner, actually, it's the patient's off to the left. In the back corner is this guy named Marshall, who I love. He's got the best glasses and funny little sneakers. He's our neuromonitoring tech. And Marshall's only job, as you know, during spine surgery, right, is to look at spinal cord function, to give feedback to the surgeons. It's impossible for me to imagine that we won't have AI tools that will change what Marshall does, how it interfaces with us, how we put all this information together. I know that there are things that I miss. There's subtle signals that I don't recognize that machines could help us be more effective clinicians, and I look forward to thinking about that. This Perseus A500 anesthesia machine was released in 2012, meaning it's roughly 10 years old now, but based on 20-year-old technology. Is anybody here using an iPhone 5? No. So I think there will be tremendous changes in how we think about the integration of technology in the workflow, and I look forward to thinking through those with some of you. That's all I've got, and Patrick, if we have time, I would be delighted to have a conversation if there are questions from the audience.
Please, round of applause. As we go into the ferns, I've got microphone 2 if it's on. Oh, we have another one here. Great. Certainly open up since we've already got a willing questioner ready.
Wonderful presentation, Jesse. Today, I don't know if everybody realizes, National Patient Safety Awareness Day, and I don't know how this happened. It's also National Physician Suicide Awareness Day or Prevention Day. So wanted to know, what is the AMA's take on tackling this big issue? And it often is like one of the most taboo things to talk about between doctors. So what do you think about that? And is it related to burnout? And also,
Yes.
Physicians complain constantly about having to chart and interface with EMR. So how can we make that a better process?
Yeah, thanks for the question. So physician wellness, preventing burnout, restoring joy to the practice of medicine is a tremendously important priority for the AMA. The link to technology is that 5 years ago we did a national survey of physicians. Does anybody know what the number one job dissatisfier at that time was? EMR, right? It's gotten a little better, but not where it needs to be. So when I think about all of the non-value-added clicking that I have to do, and I'll be honest, I think as anesthesiologists, we get out of a lot of what my internal medicine colleagues get stuck dealing with. The cutting, the pasting, the sifting through thousands of pages of notes. It's probably a little different from our pain folks. But we have to do better, right? We need to think about, what are the essential things that we do? How do we, to steal a page out of some of our colleagues' books, practice at the top of our license, right? And do the things that require physicians' capabilities and not the busy work that sucks the energy and the joy out of it. So that's a big focus for the AMA. We have a whole lot of projects. We do a lot of engagement with health systems to do burnout assessment, look at systems opportunities to improve care delivery aspects. And I think on the suicide piece in particular, we have to acknowledge it. We have to talk about it. It's strange. So other professions, the more training you have, whether you're an attorney or a banker or whatever, advanced degrees, is protective against suicide. That's not the case in physicians. We are an outlier, and I think it's because of all of the systems and things that we endure, all of the paperwork, the regulatory burdens, the things that, again, suck the joy out of what we do, that have caused that.
Great question. While we await another questioner, if that's okay, Dr. Ernfeld, I wanted to ask what your thoughts were on the actual so you mentioned some of the difficulties about appropriating AI in individuals or smaller groups. I'm curious what you think is the number one reason why people are resistant to incorporating some of these methods into their practice.
Yeah, there's fascinating research. And if anybody wants to follow up, there was a wonderful Harvard Business Review article that summarized the data on this beautifully about 2 years ago. I can send you the reference. And it's this. Patients were asked if you could have a pacemaker implanted using some AI tool versus your doctor, and the AI tool will do it safely, more efficiently, less expensively, what would you choose? Consumers choose the doctor because they believe that they are uniquely different than every other human on earth, and they want their doctor to understand that and make those decisions for them. So right now we have this sort of strange consumer confidence issue that you understand why, right? And until we resolve that, until there's transparency around how these technologies are developed, what are their drawbacks, we're going to run into, I think, some real challenges.
So, Mary Dale Peterson, thank you, Jesse. Excellent talk. And kind of along those same lines, maybe some of that skepticism are things like, we've had pulse oximeters since the 1980s, and we're only now realizing that they're not that accurate, perhaps, in people that have darker skin colors. And so to me, that's a failure. The recent July issue, I think, of Anesthesiology, we've had all these articles about these algorithms that can predict hypotension, and then a group of people from the Netherlands basically said, wait a minute, you guys didn't do this right, it really doesn't, you're overweighting certain things. So, it's like, what do we need to do differently to make sure we're not missing these things or making these errors that then in turn make people more skeptical of AI?
Yeah, so I think it's a global issue about trust in science and trust in medicine that has implications for us. And some of this we have caused ourselves, right? There is an unfortunate history around biomedical sciences that has been unfortunately not inclusive, and in some cases has taken advantage of marginalized communities like the Tuskegee studies, that we still suffer from the remnants of the perspectives after those experiences. I was at a dinner with the CEO of a pharmaceutical company that will remain nameless. It's a small company. They do interesting things. And he was telling me about a product that they are working on. And I asked him, I said, where do you do your clinical trials? He goes, I have no idea. And I said, so you must contract it all? Yes. I said, okay, so how do you guys, and you're the CEO of the company, how do you think about making sure that you've got representative patients in your trials? He goes, we don't. And until we have either companies that do that voluntarily or regulatory approaches that require it, we're going to make these mistakes over and over and over again. It is really hard to get rural patients enrolled in clinical trials. Well, guess what? There are a lot of rural patients in the world that probably have some differences for lots of reasons. Same thing with people of color, marginalized communities, LGBT individuals. The pulse oximetry challenge, and I was invited to participate in a conversation with the FDA around, what do we do next? What do we think about this? Is really on us, and I think as a result, we have to make sure that we don't let those things happen again. I will tell you, the pessimist in me says that we're set up to continue to have these failures.
So obviously you do this at scale and on a large scale, and drive change nationally and globally. What do you say to the individual physician or small group that wants to incorporate some of this technology but doesn't know where to start?
Yeah, so, look, everything is local, right? And, on Thursday, I was in the OR taking care of patients, and I watched things that didn't happen the way that I know they should have, right? It's when you've got 300 steps in any process, and we're relying on me or the nurse or the scrub tech to remember to do something, there are mistakes. And so I think there's so much opportunity in the not sexy, mundane stuff to make sure that our processes are reliable, that can be backstopped by technology, that can be simple clinical decision support. It can be all of these things that are out there well described but haven't been implemented at scale that, again, can elevate the value that we provide as perioperative physicians to our patients.
Hi, Jessica Omaha. When the Da Vinci robot first came on the market, one of the proponents and positives that was projected was not only better surgeon positioning, but also possibly maybe someday in the future a remote surgeon could be able to be at a station and assist with the surgery while the person in place was able to also be able to assist. Do you see a role in the future where multiple different rooms manned by many different people could be augmented by having remote expertise helping out and directing some of the management of care in the intraoperative period?
Yes. So imagine you've got an iPad and you've got 10 rooms on it with video feeds and maybe some data, and you can see a little red box around one of them where a system has told you something is amiss, right? There's some signal of early hypotension, or you can see that there's a lot of motion and people are hanging blood or doing CPR. Those approaches are real. And if you have tools like that, I can give you 6 centers that have developed things like that. You can't buy it off the shelf, they're in development or licensable. If you have tools like that, then our work changes, right? As a supervising individual when you're working in a care team model, certainly. I think, right now, I rarely work with 4 nurse anesthetists. Sometimes, it's usually 3-on-1. Tools like that allow you to go to 5-on-1 or 10-on-1 if you can staff to acuity and have the right technologies to ensure those things. So I think there's a lot of potential for these things to be helpful. I was in a robot room on Thursday thinking to myself, I used to complain about how long it took and these things, and then you see the patients walk out of the hospital that night, and I see the things that the surgeons do that were never even fathomed with the Da Vinci robot when it came into the marketplace, and it's impressive. So I think that all of these tools will open up doors that we can't even fathom today.
Thank you.
I have one last question. Certainly, I know that health equity is a big concern for you, a big part of your work. And I know that a lot of what we talked about today is about things, and how do we, those of us interested in helping underserved communities, or even in your own work, how do you apply the concept of work with things to people that don't have the ability to perhaps get those things?
Well, look, all of us can be advocates for the patient in front of us, and I've been in some very uncomfortable situations. I'll tell you one where as the patient's going to sleep, but they're not asleep yet, a completely inappropriate, offhanded comment was made by somebody who worked with me in the OR about their size, their race, their gender, their disability status, whatever it is. And I can remember very distinctly shortly after I started working at a place that I no longer work, this happened, and I was like, what did I just hear? So after the patient, was successfully induced, airway secured, I pulled that person out of the OR and we had a conversation. I said, this is what I heard you say, and I don't know if you recognize the patient was still awake or not, but they heard you. And I don't think that this is what you wanted them to hear. And he was really taken aback. And sometimes it takes a little courage to have those conversations with folks. But when we see challenges, when we see the failures that we're all subject to, because look, we all suffer from the human condition and nobody's perfect, help each other be the most successful individuals that you can. And by standing up for the patients in front of you, ultimately we can make the world a bit better of a place.
Excellent, thank you. Are there any other questions from the audience? Anyone else have anything for Dr. Ehrenfeld? I'd just like to give you my sincerest thank you and appreciate you coming here and talking to us as a group. Can we please give Dr. Ehrenfeld a round of applause?
Thank you so much.